Okay, so this brief video is just going to go over and answer some questions that pertain to ketamine as an analgesic agent. Overall, this will just provide more information and just a constant review of the new medical directives coming and just the different therapies we are getting. So for the first question, is ketamine as an analgesic? So if we get into it, how effective is ketamine for pain management compared to traditional opiates? So to align with the current evidence and as well as just kind of universal perspective of ketamine as an analgesic at this point in time in the pre-hospital setting, it's not a first-line analgesic medication. Like fentanyl, morphine, and the other therapies we have are exceptional at what they do. They provide sufficient and optimal amounts of analgesia in most patient circumstances. But some patients may need a more multimodal approach because sometimes it's a suboptimal dosing kind of regimen, but overall, the overarching theme is that ketamine is not a first-line analgesic medication. It should be given with an opiate for that multimodal approach, which means you give different medications that have different mechanism of action to overall achieve desirable effects. Ketamine has some utility for patients with opioid use disorder. So obviously, if patients have a substance abuse history and they've used fentanyl and overall they've managed that kind of substance abuse and they're like, I don't want fentanyl or morphine, and that's totally understandable. That's their personal preference, and that's totally understandable to provide that patient-centered care. So that's where it comes in. Also, ketamine can be given as an alternative to opiates if their patient is contraindicated for an opiate. So that makes sense. It's just one more tool to use, but again, we give it with an opiate to overall achieve that multimodal approach. So if we look kind of at the side effects, the question is asking like, what are the potential risks and side effects of ketamine? Does this include dissociation, hallucinations, or long-term neurotoxicity? So this is interesting. Ketamine is generally pretty safe when dosed appropriately. So that's the key for the sub-anesthetic dosages, because ketamine is pretty versatile depending on the dose that we give it in. So different dosages effects, but the analgesic dose is extremely smaller than the anesthetic dose. So typically under our medical directives, the analgesic dose is 0.25 milligrams per kilogram for the intravenous route and 1 milligram per kilogram for the intranasal route. So for somebody 18 years and older, they should receive a max dose for analgesia purposes, 20 milligrams for the IV route. So typically at those dosages, the side effects won't commonly occur. Ketamine has been found to cause laryngospasm in a small subset of the population, like under 2%. However, that's usually from higher anesthetic dosages given fast push by the intravenous route. So that doesn't really apply to the analgesic dosages, but that's also a good point that we do a slow push generally over 2 to 3 minutes if we're giving ketamine by their intravenous route to mitigate those side effects. Again, we're not trying to achieve dissociation with the analgesic dosages. We are just trying to provide analgesia and anxiety lysis, which indicates that we're trying to alleviate their anxiety. Because obviously there's an intersection when someone manifests in pain from an injury or trauma that they're going to have anxiety. So if we give an alleviation of that, that can provide optimal relief for their current state. Again, hallucinations not common in the analgesic dosages or long-term neurotoxicity. Ketamine is generally quite safe when dosed appropriately and given for patients that meet its criteria. So common other side effects include hypersalivation, again, not common in the analgesic dosages. Ketamine can exacerbate schizophrenia in patients prone to schizophrenia, but again, not typically seen in these dosages. And there is a concern about the emergence phenomenon, which is basically like they get this paradoxical reaction where they're hallucinating, they're agitated, they are almost in a state that resembles schizophrenia. But again, not typically commonly occurring with these dosages that we're giving. So it's pretty safe when dosed appropriately. So the optimal dose for the intravenous route for somebody 18 years and older is 0.25 milligrams per kilogram to a maximum dose of 20 milligrams. So based on that medical directive, anyone 80 kilos and up should get the maximum dose. But our current concentration is 500 milligrams in 10 mils or 50 milligrams per mil. That would equate to drawing up 0.4 mils to give you that 20 milligram dose. For the intranasal route, It's 1 milligram per kilogram to a maximum dose of 75 milligrams for somebody 18 years and older. So technically anyone 75 kilograms and up should receive the full dose. And that's 1.5 mils of ketamine based on our concentration. For pediatrics, it's 0.25 milligrams per kilogram for a patient 1 year old to less than 18. But there's a caveat here that we patch for somebody less than 18 years old, because even though when ketamine's dosed appropriately and given for specific criteria, it's generally pretty safe, but they're at higher risk of side effects. And again, just with the concentration, it's optimal to talk to the base hospital physician to confirm the dose and confirm how you're drawing up and giving it, just to mitigate the side effects and ensure that accuracy of the dose. Because ketamine is a high-risk medication, along with opiates, as long as dopamine, epi, or epinephrine. It can lead to adverse events, especially when dosed inappropriately or higher than what's desirable for each and every patient. So that's the key thing to take away. And for the intranasal route, for the pediatrics, again, it's 1 milligram per kilogram to a max dose of 30 milligrams, and the max dose for intravenous biomedical directives is 10 milligrams. How does ketamine's NMDA receptor antagonism contribute to its analgesic effects? So a good kind of analogy, just to remember agonistic action versus antagonism. Agonist action's like putting further gas on your car when you're driving. So agonist action just amplifies the current response. So I'm putting more gas on the car, but antagonism does the opposite effect. So it applies the brakes. So ketamine binds to the NMDA receptors, and at the analgesic dosages, it usually binds to like less than 50% of them. So that's why it achieves analgesic dosages. But if we give higher dosages, like for dissociation effects, that binds and saturates more of the NMDA receptors, which overall blocks glutamate. Glutamate's that typical and most abundant excitatory neurotransmitter. So if ketamine binds to the NMDA receptors and blocks glutamate from binding it, this reduces sodium going into the cell. And overall, that leads to an inhibition of pain transmission, and overall leads to analgesia and anxiety lysis, or the alleviation of the patient's anxiety. So again, ketamine, when binds to the NMDA receptors at analgesic dosages, typically binds to less than 50% of them. So that's sufficient amount of binding to lead to these analgesic effects, but it's not high enough to actually create dissociation. So that's the key difference. So in what clinical settings is ketamine most appropriate in the pre-hospital setting? So under our current medical directives, it's basically all up to the patient, what they're experiencing, their pain relief based on the opiates, if they're contraindicated for anything, because again, ketamine should be given with an opiate unless they're contraindicated or they have opiate use disorder and they don't want to receive an opiate analgesic medication. So ketamine can be administered if patients are achieving suboptimal results from their current opiate or what they are experiencing, and ketamine can be added in as this synergistic effects or this multimodal approach. However, ketamine has been truly seen to be quite beneficial in the pre-hospital setting for patients experiencing like trauma, especially if they have a reduction in their blood pressure from traumatic hemorrhage or traumatic injuries, because ketamine can actually increase their blood pressure from the release of catecholamines from the adrenal medulla. Ketamine can also be beneficial for those patients experiencing burns. Burns is one of the most excruciating things a patient could experience. So if they can receive an opiate plus ketamine, that has been empirically shown to achieve desirable effects and overall lead to optimal analgesia and anxiety lysis. So ketamine can be given for different patients' pain, different pathologies, different clinical situations. But again, we should try the opiate to see if we can get optimal dosaging and optimal relief. Then if need be, we can give ketamine as a multimodal approach to overall reduce the amount of opiates used, overall achieve optimal analgesia and anxiety lysis. So does ketamine pose a risk of addiction or abuse when used for pain management, especially compared to opiates? So this is a key point to kind of take away. What we give for analgesia in the pre-hospital setting does not cause opiate addictions. 50 to 90% of all people that experience opiate use disorder, it typically stems from a prescription med. And there's obviously higher risk populations that are, of course, higher risk to getting opiate use disorder, and this can involve like high risk populations, marginalized groups, Men are disproportionately affected, especially younger males, European ancestry, if they have a history of sexual abuse or violence, which is quite unfortunate. You can see they go through a comprehensive list of risk factors and everything. But again, we need to give analgesia because it's incumbent upon us to alleviate their distress and pain. That's a main focus of patient care in the pre-hospital setting, in the in-hospital setting. And if we don't treat that optimally, that can lead to very negative consequences, such as PTSD, anxiety, depression, delayed healing, adverse outcomes in the in-hospital. You have to stay longer in the hospital, and this just ripples. So again, what we give, opiates or ketamine in the pre-hospital setting, should not cause addiction. But does ketamine have a risk of abuse? Typically no. Because again, we're giving sufficient amount of analgesia to alleviate their distress and their anxiety and give them optimal pain relief, which is necessary as healthcare providers. Out of the dosages we give, it is quite safe and effective to do so, and it has not been indicated for abuse. Obviously, some subsets of the population use ketamine recreationally, but that's a totally different experience and dose, and they're not being monitored appropriately as they would in the pre-hospital or in the hospital settings. Is ketamine safe and effective for specific populations such as children, the elderly, or those with comorbid conditions? So yeah, different populations can have different risks to the adverse events of ketamine. Again, at the analgesic dosages, they're unlikely to occur, but they may happen. Populations that are disproportionately affected by the adverse outcomes are children, as well as elderly, because what if they're on medications? What if they cannot clear or break down the med as comprehensively as adults that have functioning livers, etc.? Comorbid conditions, again, when dosed appropriately, ketamine's been demonstrated to be safe, effective, and achieve desirable effects. But this is why there's a good quality assurance point in the medical directive that anyone less than 18 years and old, they will have a patch point just to confirm the dose, what the patient's experiencing, and overall just review the math because their concentration is not ideal for the analgesic dosages. But again, we have resources at your disposal to use for you to have that safe and effective med administration and delivery of it. So overall, ketamine is quite safe and effective, even for populations that are disproportionately affected by outcomes, but that's why it's always beneficial to confirm your dose, draw it up appropriately, administer it over 2 to 3 minutes, and have that discussion with the base hospital physician to confirm that dose for anyone less than 18 years old. So how does ketamine's mu-opioid receptor agonistic actions contribute to its analgesic effects? So this is very interesting. Ketamine can bind to a variety of different receptors, and one of them is the mu-opioid receptors, which are abundantly found in the brain, the spinal cord, which overall involved in pain transmission, perception, and the subjective experience each and every individual will experience based on the pain and their injury. So mu-opioid receptors are involved with ketamine and its analgesic effects, but in comparison to its NMDA receptor antagonism, it has quite a low affinity to the mu-opioid receptor. The main primary analgesic effects that ketamine exerts is based on the NMDA receptor antagonism, but it causes agonistic actions to the mu-opioid receptor. So if it binds to it, it leads to optimal analgesia. It can lead to this reward and sense of euphoria, and overall this contributes to its anxiety lysis. So when ketamine binds to the mu-opioid receptors, again, at smaller amounts in comparison to the NMDA receptors, it can lead to analgesia and reduce the patient's anxiety. So overall, this is part of this kind of contributory effect of achieving desirable effects for patients. So what are the contraindications to ketamine in our medical directives? So in the current edition, or the 5.4 edition, ketamine's contraindications align with the opiates. So obviously allergy or sensitivity to ketamine, that one always makes sense. So the next one is the treatment of chronic pain. So patients with chronic pain have very specific and tailored kind of treatment plans for them. They have specific medications, they have particular dosages, and we don't want to disrupt and interfere with that plan. So that's why opiates and ketamine are not indicated for that. Plus, if you look at the empirical evidence, like ketamine for chronic pain is kind of unique and just kind of evolving at this point in time. So we're just involved in the acute management of pain, and that's why ketamine just should be given with an opiate when patients are experiencing acute trauma, pain, and overall have suboptimal relief from whatever they're experiencing. So that's why we do not give opiates or ketamine for patients experiencing chronic pain, because we could disrupt their whole specific treatment plan, which could lead to negative consequences down the line. In addition, headaches, contraindicated. Obviously, if patients are manifesting with a headache and they don't have any neurovascular compromise or not suspecting a stroke, and it's just like a headache in nature, which could be from a slew of different pathologies and etiologies, you can give Advil and Tylenol for that. Those are very beneficial analgesics, especially for headaches. They do not need an opiate or ketamine in the pre-hospital setting. Let the in-hospital setting deal with that stuff if they choose to give it or not. That does not apply to us. And again, patients that are pregnant and are in active labor, ketamine is contraindicated for them. There is no role for us administering opiates or ketamine in the pre-hospital setting for labor, even though that's empirically known to be one of the most painful things anyone could experience. We do not give analgesia for those patients experiencing an active labor. That does not apply to us in the pre-hospital setting. They give medications in the in-hospital setting that are specific for those circumstances. They're being monitored appropriately by multiple healthcare providers with different specialties, different abilities to assess those patients. That's not our role, and that's why it's contraindicated. Do we give an opiate and ketamine co-administered like at the same time, or is it sequential? So there's a line in the medical directives that we do not give them fentanyl, then fast push fentanyl and fast push ketamine. No, we don't do that. So it's sequential. So we try some fentanyl or morphine, then we wait the amount of time for it to render a desired effect, which is based on the dosing intervals. So our dosing intervals are quite evidence-based because fentanyl is pretty fast acting and does not last as long as morphine. So that's why the dosing interval between fentanyl doses is 5 minutes, because usually it starts to work in that time. Morphine's about 15 minutes. So those dosing intervals start when you're done your aliquot dosaging, because the best thing about opiates is you can dose it up appropriately based on aliquots to give the least amount of analgesia slowly to mitigate the side effects and overall achieve desirable effects. But if we give ketamine, the dosing interval for ketamine is 15 minutes, because that's usually when it peaks to work. So always the medication you're giving, the time interval to the next dose is based on the last one you administered. So if the last medication you administered, you have to wait 5 minutes to give another dose of fentanyl or ketamine. But if you give ketamine, the next drug you can give, which could be fentanyl or another dose of ketamine, has to be 15 minutes to let it work before you move on to the next medication. And a common question is, can you go back to fentanyl once you give ketamine? Of course. So we can give ketamine under 2 dosages under our current medical directives, 15 minutes in part without a patch at this point in time. But again, you can give that multimodal approach by going back to each medication based on the appropriate dosing interval under our current medical directives.